The vast majority of my practice is immediate breast reconstruction, probably 95%. And then the other 30% of my practice is cosmetic plastic surgery. So SPY is the only thing that I've found that is superior to clinical judgment, in my opinion. So I don't use any other technologies. And none of those technologies that I had looked at previously, I really adopted. I tried them out, and I thought they were, at the end of the day, less accurate than my clinical judgment. There's another place where it's really made a big difference is in deciding how many perforators to take in a DIAP flap. You know, every perforator you take above 1 means that you have to divide muscle and you have to destroy muscle. So the fewer that you can take, the better. But what people have also learned is with the DIAP flaps is that there's a higher incidence of fat necrosis and compromised outcomes in the breast. So you want to take just the right amount. And so I think, again, we now are taking, to be honest, fewer perforators in our DIAP flaps because we now have a good handle of how many we need to really perfuse the tissue that we're going to transfer up there. It also lets me, really push the envelope in terms of how much volume I can place into a tissue expander. And I've found that actually I tend at this point to have most of my tissue expanders half to 2/3 full at the end of the case, which wasn't my practice before because I was so afraid of compromising the mastectomy flaps. And now you can actually see in real time the effect of different volumes on the mastectomy flaps. So I think for me as a surgeon, it lets me very rapidly know how compromised mastectomy flaps are, or how robustly vascularized my free flaps are. And so it actually helps me make rapid decisions and kind of, as opposed to looking at something and waiting a few minutes and looking at it again, and which is kind of what my practice was beforehand. So I can very quickly make decisions about what's viable, what's not viable. But our initial, the reason we use it is that I think it has, eliminated some of the problems we used to have that used to be a real nuisance for the physician and a real problem for the patient. I find that it's better than my existing judgment, be that good or bad, after 10 years of practice. And to me, I find that to be useful. I can only say that when I started out, it would have been more useful because, as I alluded to, my complication rate is now lower than it was before. So that implies to me that my clinical judgment wasn't adequate. For the patient, I think the benefit is that this has the potential to decrease complications, and we found that, at least in this early experience, we've been able to drop our complication rate by about 2/3, which is, I think, at the end of the day, something that's very beneficial to the patients. I have the opportunity to do a lot of breast reductions in radiated breasts, and there always is the concern about the nipple viability and the viability of the skin flaps. And again, I think this provides an unequivocal metric or barometer for how healthy the nipple is and how healthy the skin flaps are. In 2 cases that I can think of, I thought things were okay that SPY would have predicted would not be okay, that turned out not to be okay. So that was, it got me at least interested in the technology. Subsequently, it has, my rate of mastectomy flap necrosis has virtually gone to 0. Now, again, that's, was probably 5 to 10%, or maybe a little less than that in the previous, 200 cases that I'd done. But I can't remember the last time in the past year that I've had to debride a mastectomy flap in the clinic, which used to be, once a month or so. You'd have a patient in the procedure room where you're debriding a mastectomy flap. So that, I think, clearly it makes a big difference. We're now able to offer patients more options than we were previously, because I think we're able to make a much more accurate assessment of the likelihood of perfusion problems post-op. The field of breast cancer surgery is evolving at a very rapid pace, and I think that having a direct communication and a close relationship with the surgical oncologist allows you to provide tools to them so they can try to do more and more advanced operations. And in the context of breast surgical oncology, that really means leaving more and more tissue behind safely. For the patients, I think we can offer more advanced techniques to more patients. So although, again, as I alluded to, it's very controversial within plastic surgery about what to do with a patient who's had previous radiation. I think with the ability to really predict how the tissue has responded to surgery and how it's behaving intraoperatively, I think we feel more comfortable pushing the envelope more. And so I think more and more patients will have a wider variety of options for breast reconstruction. The one group of patients where I do explicitly discuss SPY with are the patients where we're kind of pushing the envelope and we're doing something that previously I probably wouldn't have done because I would be uncomfortable with the high risk of complications. But here with a patient who's been radiated who potentially maybe wants to have or an attempt at nipple-sparring mastectomy, or a patient who who's a smoker who might want that, I'm willing to take that on, and there I tell the patient, I'm going to use this machine to determine whether or not this tissue is going to live. So I think we've made the breast surgical oncologists more comfortable doing these more advanced techniques because they know that they're not necessarily going to have a higher complication rate. So I think that's been very important in kind of the way we take care of patients at Stanford. Because with complications in breast cancer patients, sometimes that can delay chemotherapy, delay radiation. All those things, even if they don't have a long-term effect on mortality, are incredibly anxiety-provoking for patients. And so, I think our complication rate in immediate breast reconstruction, if you look at it with clear eyes, is too high. And so I think what SPY really offers potentially is the ability to lower that so that you don't have these problems post-operatively. The ability to actually have a very robust, very unequivocal, real-time assessment of that in the operating room, to me, I think has a potential to make a very big impact on complications. And I think that's where the value is going to lie, rather than guessing or using clinical judgment as good as it is. I think having a tool to say, this is potentially not adequately perfused is very useful. But I think if it pans out in the way my experience has panned out, I think it will be quite a large part of surgical practice in a variety of different settings, including cardiac, general, colon rectal, plastic surgery, thoracic surgery, where again the whole ball of wax is maintaining perfusion and knowing if there's not adequate perfusion so that you can do something about it in the operating room.